Welcome everyone. I hope I'm audible.
Yes, you are.
Yeah.
Okay, so this is a case of 45-year-old.
Ahmed, just a minute. You can introduce yourself. Dr. Ahmed is our chief
Okay.
resident at Al Khan University Hospital and neurosurgeon.
So after that introduction,
Yeah, and now you can present the case.
Sure, Dr. Hassan. So this is a case of 45-year-old right-handed lady whose current KPS is 90. She's a known case of right breast carcinoma, IDC grade 3, and she underwent neoadjuvant chemotherapy 4 cycles, and after that she underwent right-sided modified radical mastectomy in April 2022, followed by 30 fractions of radiation to the chest in June 2022. Currently, she was on tamoxifen when she came to our clinic with complaints of headache and memory disturbance for 1 month, and that was 2 months ago. So a pre-op MRI brain was done on 18th of June 2023, which showed, Dr. Hassan, can you please move on to the next slide? So the first slide is, these are the scans of T2 axial.
Ahmed, you can briefly discuss the scans because then we can ask if Dr. Shumail or Dr. Shayan wants to add something. Yes, please go ahead.
Dr. Hassan, please move on to the contrast image so I can tell them. This was a solid cum cystic contrast enhancing lesion. Next, please. And on FLAIR, we can see that there is some surrounding edema.
Dr. Shayan.
And Dr. Shumaila, if you want to add something to these scans.
What was the size of the tumor this met?
Exact size. Okay.
So, sir, it was almost 8 by 6 centimeters.
And it was
this whole solid.
Okay.
Dr. Shayan?
Yes, so on this post-contrast, in the lower row of first image to the left, we can see that this is a well-circumscribed and solid cum cystic lesion. The solid lesion is more medial, and there's also rim enhancement of the cystic component. But it appears to be well circumscribed and causing a lot of mass effect and vasogenic edema. In the upper row, you can see on the FLAIR sequence, it is causing a lot of vasogenic edema. So based on the history, the first differential will be that of a metastatic deposit. And Dr. Shumaila, if you want to add something.
Yes, it looks like a metastatic deposit because we know the history in this case, and the solid component is actually more along the medial aspect of the lesion. The cystic component is also showing enhancement. To me, there was some possible enhancement along the Pecchi meninges on the same side. They appear a little prominent on post-contrast images. They are different from the other side, so probably I'm not sure that there is meningeal disease in this case or not, because we can't see I can't scroll whole of the images, but in these images there is some pachymeningeal prominence as well. In this one, yeah. The first image in the second row, the meninges, they appear a little prominent to me, but
so basically, it appears to be dural based. We also see a dural attachment of this tumor in one of the sections on coronal view. So it's very typical of a METS.
Yes, and especially the edema, which is very extensive.
So this is the single lesion. There are no metastases anywhere.
Yes, sir.
Okay, I think please move on to the next.
Yes.
Slide. So with this history of breast carcinoma, our first differential was metastatic breast carcinoma. So we got a PET scan done, which showed deposits in L5 and D10 vertebral body and some hypermetabolic lymph nodes in the right axilla and mediastinum. So after this, because of the mass effect, the size of the lesion, he was planned for surgery, and she underwent neuronavigation guided left frontal craniotomy and maximum safe resection of the lesion in August 2023. Her case was then discussed in Neurotumor Board at Khan, and it was advised that receptor status, along with systemic chemo and focal radiation to the spine and the chest lymph nodes should be done. So after that, patient had some wound site collection, so a post-op MRI brain was done. These are T1 axial images. Dr. Essen, can you move on to the next slide? So these are post-contrast images, and we see that there is some residual disease in the medial and posteromedial margins. Dr. Shahan and Dr. Shmaila, if you want to add something on these scans.
Okay, so I reviewed this case, and to me, it looks more of a post-op changes rather than a residual tumor, and we need to follow up in 3 months' time.
Okay.
Okay.
Dr. Shan, intraoperatively, there was a lot of bleeding from the medial and the posteromedial margin. So we knew that we were leaving some tumor over there.
Yeah, because most of the solid tumor was there in the posterior
Yes.
and medial aspect. So that must have blood. You see a lot of blood here in the resection cavity as well. And the enhancement is very not slightly thick and nodular, but again, you don't feel that there is some solid component over there. But still, we need to follow it.
Okay.
Dr. Shumaila?
As far as my experience with breast metastasis, especially by working in CyberKnife, is that there is always a residual left because breast tumors they have very aggressive metastasis. So I would not entirely exclude, although there is hemorrhage on T1 plated images, but the meninges, they still look very odd to me. And even if I look at the surgical bed and the bone, that area, does not look very clean to me, even in these cases. So the major component is definitely removed, but I'm still concerned about that meningeal disease.
Okay.
So after this immediate post-op scan, we followed the patient, and she came out to be triple positive. The biopsy that we sent from the brain metastasis. Dr. Essen, can you please move on to the next slide? So she developed a wound site infection, and she underwent wound debridement in October 2023. And for radiation planning, a follow-up MRI was again done in November 2023, which was just recent. Which again, this is just a planning MRI. So on the above images row, we can see T1 plain axial images, and the lower row shows T1 post-contrast axial images.
So this time you could see the recurrence, right?
The residual, yes. Can you move on to the previous slide? Another previous. Yes, in this you can compare in the third image from the left, you see on the top is T1 axial plane, and below you can see T1 post contrast. So here you can see the nodular enhancement, which is posterior to the area of bleed. And similarly, in the fourth image, you can see nodular enhancement, which is also extending and involving the meninges and the overlying bone. So is this a post debridement scan?
Yes, this is post debridement. This is 1 month, almost 1 month, 20 days post debridement.
Okay, and the patient must have been on medications as well.
Yes.
So this is an area of abnormal enhancement, and again, of course, raising strong possibility of a residual disease.
Yes, I agree, because I think the recurrent disease, I will call this recurrent possibly, because a lot of it was removed. Probably it was at subcellular level, but even in the surgical bed and in the bone flap, you can see this enhancement going. The last image in the bottom row. So even the bone table is not good in this image. And there is a lot of enhancing tissue which is extending in this surgical bed, which is not seen in the pre-contrast images in the above row. So to me, yes, there is a new recurrence of the disease.
Okay.
So the query to the board is if we should proceed with surgery or proceed with radiation with this history, and knowing that she's prone to have wound infection. She already had a superficial wound infection, which was debrided. Now, should we, and she has poor wound healing as well.
So, Dr. Mashra, the first, I think,
Yeah, I think because she is now metastatic, she has met development in the spine, and I think they were, as I've heard, if I'm right, that she had nodes in the axilla as well. So she has distant mets, brain mets. I wouldn't actually go for a second surgery at this stage because she had post-op infections and all that. She should be, there are two options. Either because there are no mets in the brain anywhere else, she can have SRS or cyber knife to this cavity. But again, the cavity initially, the tumor was, if I am right, it was 7 centimeter. It was pretty big. So normally such a big cavity is normally not radiated with SRS. The cutoff is 5. And secondly, in breast cancer, my experience in treating breast cancer in last 30 years is that it's not single cell that goes to the brain. Later on, other mets also develop. So I would rather give her whole brain radiation if now she has recurred again, and just treat her with hormonal treatment. And if she is HER2 positive, she can have Herceptin or pertuzumab. That also helps in the brain metastasis as well. So if she was my patient, I would give her whole brain radiation. She's metastatic distantly in the bones and in the axilla. She should start hormonal treatment and Herceptin or pertuzumab, whatever.
Right. Thank you, Dr.
So, Dr.
We have
Masud,
Dr. Riaz also with us. We can ask his opinion also. Assalamu alaikum, Dr. Riaz.
Walaikum assalam. Actually, I didn't heard the history because no, I was just late. My question is that most of the presenters and also the discussants were in favor of that. This must be a metastasis. Can it be a primary brain tumor in a scenario where the patient is having a primary breast disease and a primary neoplastic disease? On which grounds on the images
the pathology came out to be metastatic and ERPR and HER2 positive, so that indicates breast metastasis rather than primary brain tumor.
Okay.
Actually, Dr. Riaz, that was biopsy proven, but you are right. If biopsy would have shown something else, then of course that would be a different.
And what is the status of spinal mets? Is she
Dr.
paralyzed or?
Sorry, I'll just briefly go through the history. She's a middle-aged female with status post MRM and neoadjuvant chemotherapy and radiation to the chest for IDC grade 3 tumor last year, and now she presented with confusion and memory impairment. So she got an MRI which showed left frontal enhancing lesion. It was a solid cum cystic big tumor, almost 8 by 6 centimeters. She underwent PET scan which showed L5 and D10 lesions, a vertebral body, and she also had left axillary and mediastinal lymph nodes on the PET scan. She underwent surgery and there was some query of the residual disease. She was followed up in 2 months along with her ERPR and HER2 new status, which came out to be triple positive, the biopsy from the brain tumor that was done. And now she's
not paralyzed. Dr. Riaz was asking if she is paralyzed. No,
her current KPS is 90. She has poor wound healing, but her activities and all is very good.
So it means if our discussant were asking about the further surgery, if the patient is mobile and the patient is not, then we can find the adjuvant chemo.
Disease is not resected.
Okay.
It's because the problem with breast cancer is that once the shower of cells that are already gone into the system before starting her on chemotherapy initially, these were the cells that did not develop later on in the spine. these are the cells that were already metastasized ho chuke the at the time of diagnosis, and these cells have now started growing up in the spine and in the brain. So she has a great high grade disease and most metastases and even in the brain. So in her case, I think one should not be very aggressive. It's a palliative situation, but still I would recommend whole brain radiation to the spine if she is symptomatic from it and is hormonal treatment plus biphosphonate Zometa injections every 4 weekly, and Herceptin pertuzumab if she is affording, because that would make that helps in the brain metastasis as well as distal disease. And since she is triple positive, so all three options can be used. If she develops visceral metastasis in liver and lung, again hormonal treatment and Herceptin pertuzumab would help. That would be my recommendation because since treating breast cancer, I know that it's not once the patient develop mets after adjuvant treatment, very soon these mets start growing, and there's no point in doing drastic surgeries on her, increasing her morbidity from that. And so one should offer a treatment that she can tolerate and is less morbid.
Okay. Thank you, Dr. Kamal. We have, I think, one question also from the participants. I think Dr. Kamal has raised her hand. Dr. Kamal, you can ask your question.
Assalamu alaikum, everyone.
Walaikum assalam.
I had a question. Can we go back to the imaging, please? Because I think there was some corpus callosum involvement in the first scans that we saw. And I was just curious, because when there is corpus callosum involvement in the gliomas, we usually don't go for maximum safe resection. There is some varied review in the literature, but the generalized opinion is that it's a good idea to just take the biopsy and let the rest of the tumor be there. So, proposed guideline for METs, if there are intracranial METs and there is some corpus callosum involvement, which I think there is, a radiologist can comment, and I would be very happy for the opinion. Is it a good idea to go for maximum safe resection in such a patient?
Okay, I will let the radiologist comment on your corpus callosum, and then I'll tell my views about the maximal safe resection in it. Dr. Shayan, so there
Do
was
you
some
have coronal images?
coronal.
Dr. Essen, the fourth image is coronal.
Yeah,
Flare image.
here.
Yes, this is the flare image.
This is post-contrast T1 coronal.
Yeah.
Sorry.
I think we do not have flare also, right? Emma, do we have flare?
I think this would be enough. Here you can see that it is quite away from the corpus callosum, though it is showing some surrounding vasogenic edema, which is extending into the corpus callosum, and there's some displacement. So, considering a MET suspicious for tumor infiltration, until unless it's a primary intraaxial tumor.
Okay.
Dr.
Thank
Essen,
you.
we do have flare image, the post-op MRI, and the fourth image on that is the flare image.
Yeah.
This one. So here we can also appreciate that likely corpus callosum in the lower
Is spared, yes.
middle images. We can see that this is spared just above the ventricles.
Right. Okay, so
Actually,
Dr.
because
Yeah.
of the edema on axial images, probably Dr. Kamal thought that there is involvement. Actually, there is some subfalcine herniation and some edema which is on axial is giving a picture as if crossing the corpus callosum. But coronal and sagittal are better to decide that corpus callosum is involved or not.
Right.
Dr. Shayan.
Thank you. So I think, Dr. Kamal, the other question, I think that you will see a lot of different opinions. I know surgeons who chase the tumor into the corpus callosum, especially if it's involving only the interior corpus callosum, and they will go and they will take it out and they will chase it if it's going to the posterior. I think there's. So then they will spare it. So it depends, it depends on the experience. It depends on the surgeon's choice also. But when we call it maximal safe resection, that's the important thing. Like we are making sure that whatever we are doing, the quality of life does not get affected. The post-op deficits we try to avoid as much as we can, because there is no, kind of a point of giving someone a life that the patient is crippled. That these are the things that as a surgeon we think of when we are planning. So if we think our resection can remove maximum as much as we can the abnormal cells without affecting the quality of life that the patient will be having after surgery, then so yes, surgeons do go into the corpus callosum, especially if it's the interior part. But you might hear, I think we just have Dr. Riaz with us here. I can ask his opinion also, but we do not have any other neurosurgeon today. And we can even ask if we have some senior residents, if they want to add something. Dr. Riaz, if you want to answer Dr. Kamal's question.
Dr. Kamal's question was very valid, that if this is a corpus callosum involvement, the scenario and the presentation may be different. But I think this is the left side, and carefully it should be removed for the further radiation or chemo. Otherwise, the racial treatment regarding the tumor removal is not possible and not feasible in this case.
Right. Great.
Actually, normally in a case like this, I think even if a debulking is done, that would also relieve her symptoms. And then we post-operatively, after debulking, one can give radiation, because the whole idea of radiation doesn't completely remove that met. So if it's combined with surgery, the results are better.
So one more thing, thank you, Dr. Riaz and Dr. Mazhar. So to answer Dr. Kamal's question that only biopsy should be done if considering this was a glial-based neoplasm. So Dr. Kamal, if we can leave the part which is invading the corpus callosum and maximally or safely resect rest of the tumor, it decreases the tumor burden and the tumor bulk. So radiation dose gets decreased and it helps in that as well.
No, actually, the dose remains the same, but the effectivity of that dose become more effective because there's less bulk of the tumor, so the radiation have less cells to kill rather than a big lesion like there.
And I think that is one of the argument point also when we discuss about the surgical debulking or resection versus liquid biopsy, because in surgery we are mechanically we are removing physically abnormal cells, and that would aid our adjuvant later whatever we are giving the patient as a chemotherapy or the radiation as well.
Yeah. And secondly, it was a single lesion. So in this case, surgery is important, because if there were multiple suprainfradentorial mets, then one would not go for surgery in that case. But a single lesion, debulked is normally neurosurgical opinion. Firstly should be sought, and then once the surgeon is happy that he can remove it or debulk it, that should be done, and then adjuvant radiation or whatever can be given.
Right. Any other questions or comments from the audience? Okay, that was an interesting discussion. Just to add one thing, since we have time, so sometimes, Dr. Mazhar, if we have multiple mets and one specific lesion is causing more, kind of midline shift, causing mass effect, we might think of just, focusing on that. If that is causing some kind of life-threatening condition that we
actually think I know normally as a guidelines there is no benefit of doing surgery if there are multiple mets, because that patient is just palliative radiation and dexamethasone is enough for her, because surgery has its own side effects, and patient with multiple mets, you remove this big met and in 6 weeks time when we wait for that surgery wound to heal, another met will grow up to that size. So it's better to just straight away start her radiation within a week, starting dexamethasone 2 to 3 days before radiation.
That's also a very valid point, right? Thank you. Okay, so if no more comments or questions, so thank you so much. Thank you all for joining us today. we had just two
Thank you so
cases,
much.
and I will request all of you, to bring your cases from your centers, share your experiences with us, and it will give us, a lot of more points to see how we deal with these cases in Pakistan in our setups. Thank you so much. Thank you all.
Thank
See
you
you all
for
Thank
next
you.
listening.
month.